Burgess. It's a pleasure to be here today talking about healthcare quality, particularly with our distinguished colleagues on the panel here. When it comes to quality, the quality of healthcare in the United States, the good news is that America's healthcare sector leads the world in producing medical innovations like MRI scanners, CT scanners, mammography, drugs and other treatments for cardiovascular disease. And these innovations save lives not just here in the United States but around the world. The bad news is that the way we deliver medical care in the United States is often dangerous and backward. We lack sufficient evidence about what works and what doesn't. Even when we know what works, patients only get evidence-based care about half of the time. Doctors typically do not coordinate the care they deliver to a shared patient. And American patients suffer an estimated 180,000 serious medical errors in hospitals every year. Each of these problems is in turn caused or exacerbated by the fact that American medicine lacks basic technologies available in all other areas of our lives, like electronic record keeping, which could be making medicine better, cheaper, and safer. Now, improving the quality of improving the way we deliver medical care is an essential element of healthcare reform. The Institute of Medicine estimates that for every life lost to a lack of health insurance, we lose as many as 5 lives due to medical errors. Yet the reforms currently being crafted here in Congress may reduce the quality of care, not improve it. Those reforms would give government more control over Americans' earnings, over their healthcare decisions, and over the practice of medicine. And in healthcare, as in so many other areas, government is not the solution to our problem, government is the problem. To see how, we have to consider how markets improve the delivery of medical care. They do so through a relatively obscure form of competition between different ways of paying doctors and hospitals and other healthcare providers. There are 2 basic types of payment systems, and each has its strengths and weaknesses. At one end of the spectrum, you have prepayment, also known as capitation, or sometimes as a global budget. That's where providers receive a flat fee to provide all the medical care a patient or a group of patients needs over the course of a year. This is how health plans like Group Health, Cooperative, or Kaiser Permanente operate. Prepayment seems to work best in these sorts of so-called integrated plans, where all the doctors work for the same organization, so you don't have doctors trying to push costs off onto each other in different groups. Prepayment encourages electronic medical records, it encourages coordinated care, and it encourages efforts to reduce medical errors because when the providers save money through those efforts, they get to keep the savings. They get to keep, and that's why plans like Kaiser lead the market in offering electronic medical records. If those help to reduce duplicative testing, if those help to reduce medical errors or unnecessary services, then the health plan gets to keep the money, so they have an incentive to invest in electronic medical records. At the other end of the spectrum is fee-for-service payment, where doctors get an additional fee for every service they provide, or hospitals get an additional fee for every hospital admission. Fee-for-service payment actually discourages electronic medical records. It discourages coordinated care and error reduction, because under fee-for-service, providers get an additional fee, or they get paid more when there is duplication. They get paid more for uncoordinated care, and they get paid more when a medical error requires expensive follow-up care. The reason we suffer from these quality problems, I submit, is not market failure, but government failure. In a reasonably free market, we would have open competition between different payment systems, and that competition would force each payment system to improve. So the prepaid plans like Kaiser would offer electronic medical records. The fee-for-service plans, wary about losing business to Kaiser Permanente or other plans that make medical care more convenient or safer that way, would have to offer those electronic medical records too in order to keep those customers. The same thing would happen in reverse. Prepaid plans have an incentive to skimp on care, but competition from the fee-for-service plans would keep them in check and keep them honest. Now, we don't have open competition between payment systems, however, because government tilts the playing field in favor of fee-for-service payment. Medicare is the largest purchaser of medical care in the nation. Its payment system therefore dictates how most physicians organize their practices and how most hospitals operate. And Medicare pays largely on a fee-for-service basis. We have an epidemic of duplication, an epidemic of uncoordinated care, and one of medical errors because Medicare has chosen a payment system that rewards duplication, uncoordinated care, and medical errors. Name any quality innovation that might save money by avoiding unnecessary services, be it electronic medical record, barcode scanners for prescription drugs, surgery checklists. Medicare blocks them all. The reforms that are currently being crafted in Congress would exacerbate that problem. Rather than create open competition between all payment systems, the leading reform plans would reduce competition between payment systems. The far left is demanding a new government program modeled on Medicare for Americans under age 65. That would make even more of the market operate under a single payment system. Now, Medicare Advantage allows different payment systems to compete with traditional Medicare, yet Democrats are currently trying to reduce the role of those plans, while President-elect Obama proposes throwing private plans with competing payment systems out of Medicare entirely. Even if Congress does not create a new government program, the private sector reforms that are currently under consideration would have the same effect. Individual and employer mandates combined with a new health insurance exchange have caused government spending to explode in Massachusetts. And how has Massachusetts decided it's going to try to deal with those exploding costs? By imposing a single payment system, prepayment, on its entire healthcare sector, including including in the Medicare and Medicaid programs. Now, it makes no difference if government switches wholesale from fee-for-service payment to prepayment, as Massachusetts seeks to do, or merely tweaks Medicare's payment system, as many reformers want to do. In either case, we would merely trade our current set of pathologies for a different set, such as the extreme bureaucratic rationing that we see in Canada and Great Britain, which operate largely under prepayment or global budgets. The problem isn't the particular payment system. The problem is the lack of competition between different payment systems. We don't need government to define quality, to measure quality, to subsidize coordinated care and electronic medical records, or comparative effectiveness research in order to get higher quality care. What we need is to let consumers control their healthcare dollars, control their healthcare decisions, let them choose the health plan and the payment system that meets their needs, and competition between different plans and different payment systems will deliver better outcomes and